Well, good afternoon. I'm Beth Stewart, and on behalf of the Texas Oral Health Coalition, would like to welcome you all to the first webinar in a three-part series on teledentistry in Texas. After teledentistry passed during the 87th Texas legislative session, we found a need to provide information on the nuts and bolts of teledentistry implementation in Texas. We're extremely pleased to offer this virtual learning center series for Texas dental licensees and excited to start with today's webinar entitled Taking the Mystery Out of Billing for Virtual Visits. I also wanted to let you all know that the Texas Oral Health Coalition is publishing a teledentistry in Texas guide and checklist soon. We're going through some final edits now, but this should be available before the next webinar. Dental providers may earn 1 hour of continuing dental education credit for submitting the completed online evaluation. If you should have any questions regarding the evaluation process or need assistance, please don't hesitate to contact us at info@texsoc.org. Our presenter today is Jamie Collins, who is a dental hygienist licensed in Idaho and Washington states and dedicated to advancing the dental profession. With over 20 years in the dental field, it has led her to being involved in many aspects of patient care, especially those with higher risk factors. Jamie enjoys sharing the tips and tricks of the dental profession through speaking and writing for various publications. With over 80 articles published, she educates dental professionals worldwide. She was awarded the RDH-EA Trailblazer Award in 2021 and is the first recipient of the RDH-EA Standout 7 Corporate Hygienist Award in 2022. Jamie has also contributed to multiple textbooks, curriculum development, and contributes as a key opinion leader for various companies. Her experience has led to her being named the Professional Education Manager at Mouthwash. So please help me welcome Jamie Collins.
Beth, thank you so much. What a great introduction, and so honored to be with everybody here. So we're going to talk about the ROI of teledentistry, the billing and coding, and really what are those benefits that we have for so many of these patients that we do see. I'm going to see. Bear with me, I'm going to pull it up right here. And so let's go ahead and get started. As Beth mentioned, my background is in dental hygiene. I've been very fortunate, spent 20-odd some years in the profession at this point. I've been able to work with various companies, a speaker, a hygienist, a KOL. I do a lot with billing and coding. I actually provide testimony to the ADA every year when we talk about codes that we have, codes that we need, and what we have moving forward. I do hold a telehealth facilitator certificate. I've gone through that additional education to do so as well. And I've contributed to multiple textbooks. So if you're a relatively new hygienist, I may have caused some of your hygiene tears and pain as you prepared for boards. Full disclosure, I am an employee of Mouthwash. We have the intraoral cameras and the teledentistry software. So teledentistry is something that I dive in and really work with on an everyday basis. And I work with organizations all throughout the country, implementing with different use cases and in a variety of ways. So I am an employee with them. It's really important to understand when we look at it is what is teledentistry, because there's a lot of confusion around it as well. I do want to note too, as we go through, if you have questions, please put them in the chat or the Q&A box, and we'll address some of those at the end. So teledentistry is not a specific service. It is the method that we are delivering care. And that is very important to remember. And it really is just that communication through the use of technology. So it provides us that modality to do so. Therefore, when we talk about it, and that's where a lot of the confusion comes in with billing, is I'll hear from people and they'll say, Jamie, I billed for teledentistry and I never got paid, or I billed for it, everything else. And really what it boils down to is they probably billed for it incorrectly and therefore it got kicked out. So we're going to go through some of the basic understandings, especially for those of you in Texas that are now able to utilize teledentistry because of the new regulations, and how to do that correctly to also abide by your State Practice Act regarding it. There are two ways that teledentistry works that we have. In dentistry, we can either do synchronous or we can do asynchronous. Now we have a CDT code for both of these that we'll utilize, and we'll go over those as well. But these are the two modalities that are really recognized in teledentistry that we're able to utilize. The ADA CDT codes for teledentistry, we have the D9995 code, which is our synchronous teledentistry. This is much like we are right now. It's a real-time encounter. We have audio and visual means. So if I were dealing with you, you have a toothache, we can connect as we are now. We can get that preliminary diagnosis, and we're delivering that to the patient at the time we're connected. So we're providing that diagnosis or that care while we're connected face-to-face in this manner. That's in contrast to the asynchronous teledentistry code, which is the D9996. Think of asynchronous, the A is in anytime. It's an easy way to remember it. Otherwise, they're really easy to get confused. That information and that data is captured and then forwarded to the dentist for review and diagnosis. So you do not have to be connected at the same time. It is very, very important to remember as well, these codes are always reported and billed in conjunction with the procedure you're performing. And so the diagnostic part of this is delivered to the patient, and you're reporting that procedure on the date you're doing it. So if you're sharing the data with me today, and I'm providing as the dentist the diagnosis and review of that data tomorrow is going to be my bill date for this teledentistry code because it's at the time that it's being measured. Another good example, and we'll get into some use case examples, is how a hygienist may be able to capture this data, share it with the dentist, transmit the images, all of that data, clinical notes, reporting that we need, and that dentist is able to make that diagnosis at a convenient time. There's a lot of capabilities. So really, what can teledentistry do? We know that it removes a lot of the obstacles that we have. It's going to help streamline our approach and our connection. And many times it's that earlier access to care that's going to get patients in to see us sooner. We know that there's no travel required. When we look at teledentistry, I can do this from here. I can report with you in Texas if I hold a Texas license. So you don't have to come to me. And that's where it helps remove some of the barriers. We know that patient connectivity many times is going to prompt action sooner and definitely provides an ease of referral. So now we can connect them. If we're making a referral to an oral surgeon or a periodontist, we can connect them sooner. We also know that it works really well for remote supervision. So as a hygienist, it opens the doors of where I can go and how I treat patients and still abide within my Practice Act of supervision and have that, as well as collaboration among professionals. So we know dentistry many times, it can be kind of narrow in our network and collaboration. Now we can expand that. So we really find through case studies from everything from small private practices, mobile programs to large DSOs, it increases the efficiency and that opportunity for growth within your practice. Move forward. But when is it appropriate to use? So when do we use those teledentistry codes? We are going to use that code anytime the dental evaluation, education, or consult is completed using one of the two teledentistry modalities. either synchronous or asynchronous. Very simple in that aspect. If I call you via phone, that is not teledentistry. If we do the asynchronous store and forward, I review that data, absolutely, that is teledentistry. If we are connecting with audio and visual means through a secure platform, that is teledentistry. And we don't have to overthink it. There's a lot of concern that it's very costly to implement, and it really is not. Because we need a smartphone, a tablet, or a laptop. If, in some cases, I may need an intraoral camera. If I'm connecting with the patient at home, we don't need an intraoral camera. They will connect with their smartphone, and it's really impressive what they can capture with it. And then a form of teledentistry software, because we want to maintain, for one, our compliance for HIPAA. We also need to maintain our records. Because if I connect with somebody via, say, FaceTime, what proof and what track do I have to follow if there's ever a complaint? Also, again, we need to maintain that HIPAA compliance just as we did if we saw them in person. And there's some elements we definitely need to consider. When we document and when we look at teledentistry appointments, we need to document the reason for the teledentistry visit. We need to have that statement of confidentiality and patient rights with it. We need to document the time, the date, the persons on the teledentistry visit. In a dental office, we're a little bit more controlled atmosphere. I don't want to be conducting teledentistry visits from Starbucks when everybody in the background can see who it is. Likewise, if my patient has friends with them, we need to get that verbal consent. Who is it with you? And document who that are they okay to listen in? That way, we are not going to be held liable for violating any HIPAA procedures. And so we need to also know, is this a standalone teledentistry visit, or are we linking it to an in-person in-office visit? Is it a post-op? It is a pre-screening to come in. Is it after an initial limited oral evaluation? We also need to have a patient signature that documents the consent form. The ADA wants a consent form for any teledentistry visit. Some platforms like ours have them built in, so the patient has to acknowledge it to be able to join on that first time. So now you have it covered. We also want to look at data collection, photos, radiographs, the number of images we've captured, and document those as well. So that is our way to communicate and stay connected, all while following the same protocols we would as if they were in person. Now, Texas has set forth some requirements, and you may or may not have seen these, requiring teledentistry and what you need to have in place. Dentists must obtain, or dental offices must obtain, an informed or signed informed consent for teledentistry prior to services being delivered. This can be that online consent. So you have to have that consent in place. This consent needs to also outline the capabilities and the limitations of teledentistry. That's also very important in any consent that we have. We're going to have to be able to demonstrate the competency in an electronic platform by all of our staff members who are going to be utilizing teledentistry in any form. So this comes with training, and to document that training has taken place, probably primarily around safety and HIPAA compliance. We need to adopt protocols to prevent fraud and abuse through teledentistry. As I said, it's a less controlled environment in some manners. So we want to ensure that we're protecting that patient PHI. And always remember, regardless of what we do, we're operating within our scope of practice. Dentists we have here can do different things in dentistry versus what I can do in dental hygiene. My scope of practice is different, so you need to be aware of where you can and how you can operate with them. Texas also said there's documentation requirements for any telemedicine visit. And this is pretty standard to have some sort of verbiage around this in every state. So during delivery of telemedicine, teledentistry, or telehealth services, the documentation of services rendered must be the same as for a comparable in-person service. The service should be documented in the patient or client's record with the evaluation, analysis, diagnosis, and explanation of the treatment provided by the distant site provider. So this comes straight out of the regulations from Texas. Again, this goes with our documentation and really providing that proof that we're able to do this as well. And then, go in here. Another big question I often get state by state is, can a hygienist work in an alternative setting? Again, this comes straight from the documentation from Texas. So dental hygienists can practice in dental hygiene in an alternative setting. This includes nursing homes, patient homes, school, hospital, state institution, public health, or another institution, but it has to be under the supervision of a dentist. Again, very standard with many states we see too. There are some requirements to have in place though. For a hygienist to do this in an alternative setting, the patient must be an existing patient of record. We need to have that informed teledentistry consent signed with the hygienist named that's going to be providing services by that delegating dentist. So we need to identify the hygienist and the dentist in this case. And then we have to document, again, just as we would either in the electronic health records or hard copy records, we need to have that documentation regardless. It's also noted in there, if the supervising dentist has written a standing order authorizing the hygienist to provide whatever preventative services necessary while the patient is present, the hygienist can provide the services within their scope of practice. So what does this do? It opens the door to increase our access to care for our communities. Some of them we know, look at nursing homes, look at school settings, hospital settings, institutions. They're at a higher risk of dental disease and overall systemic disease. We're increasing our touch points across many, many layers where it's not as economically, it wouldn't be as economical to send a dentist into those settings when they can delegate a hygienist to go in for those preventative, capture the data for the screening as part of that, and let the doctor authorize next steps in treatment. Credentials and special licensure. Right now, there is no special licensure or credentials necessary to provide telehealth services. I say that with the caveat, in Washington State, it's the only state that I know of right now, you are required to take a telehealth provider training to be able to provide telehealth services. The remainder of the states, not so much. But it is very important to also note you can only provide care within the state you're licensed in. You cannot interact with patients in another state where you do not hold a license in that state. Again, some states are starting to require that telehealth training for medical and dental professionals. I think that's a trend we're going to continue to see. We have a course that's built to that Washington State standard that anybody can take that's based on best practices and really increasing that patient experience and that provider experience based on those Washington State standards. But one thing we're seeing too is the perspective from patients. One study that came out said there was a 94% satisfaction rate with their teledentistry visit. 91% said it was ease of use. 97% said they felt their needs were met. They were able to clearly express themselves. And we're seeing more and more patient demand. If COVID brought us anything, it brought us the realization that many medical and dental services can be done virtually and the benefits that we see in that. We know that there's reduced travel time. There's improved engagement because you and I are one-to-one, face-to-face. You're not being disrupted. You're not being pulled for an exam. It provides many, many opportunities in that way. We know many times too with treatment plan presentation, it's much less intimidating when we can be like this rather than in my operatory. Not to mention now, I can involve the decision maker. Do I need to involve a parent, a spouse, a significant other, a power of attorney? And we can help them understand the importance of the recommended treatment and create that value in care. I've had doctor after doctor after doctor say, you know what? I've got an increased case acceptance rate by being able to talk to everybody. Because when we hand them a piece of paper, they walk out the door and they say, let me think about it. I'll get back to you. We know there's also earlier access to care. When we start out for that first teledentistry visit, say that limited oral evaluation. Because now I'm having one visit to my office rather than two. We do that preliminary. And so when I show up to the office, we know what I need within a certain range, and it's one visit. So as a practice, it also increases my chair time, or increases the production in my chair time, excuse me. And there's clarity and understanding because I can ask those questions. And then convenience. I know personally, if I can do a telehealth visit, it's much easier for me. It's a 20-minute drive from me to town where I live to be able to interact with my doctor. And again, 96% said they would use teledentistry again. But what they also found, there was a 33% of teledentistry visits did not require an in-person follow-up visit. That's huge. We put them at mind. We've kept them out of the emergency departments. And whatever the issue was, could be dealt with at home. From a patient's perspective, 2/3 of patients thought it was easier for them to achieve their care when they could do a telehealth visit. Again, this is a different study than the last one. We know that 80% have a possibility of accessing the internet. We know it's not 100%. Not everybody has access to it. But another key point to consider is 7 in 10 patients are willing to switch providers if there's a more convenient option. So are we meeting patients where they have the need, what they're seeking out, providing that option? And there's lots of different reasons for it. We know elderly patients, mobility issues are definitely a concern. We know emergency patients, which many times when we think about teledentistry, that initial thought was emergency visits. But it really goes on beyond there too. I know a lot of pediatric that look at their children and they do initial meet and greet and kind of see what they're up against, talk about those goals in many aspects. Maybe it's a school-based program. Medically compromised patients, again, another big high risk factor group that we can help ease the burden on. Coordinating care. And we know HIPAA compliance varies by state. So there's a federal standard and there's a state standard. You will be held liable to the more strict of the two if it ever comes down to it. So you always want to use a HIPAA compliant program to maintain this. But it also does create other opportunities, as we said. We think of public health. We have school-based programs. We have long-term care facilities, FQHCs, rural access. We know Texas is big. There's a lot of areas it could be. I know in my area, we have a strong migrant population, and they're using it to help reach some of those individuals as well. Private practice. We have post-ops, extended hours, mobile programs. Think about our post-ops. 90% of these, we don't do anything but look. So we could free up that chair time by having those post-ops virtual. Group practices, we see it with collaboration referrals, clinical collaboration with labs. We see it in a variety of ways. We're also seeing more of it in medical dental collaboration. Putting an intraoral camera into a pediatrician's office. It now becomes part of the well child check and they make a referral to the local practice that they're working with. Home health agencies, hospitals, emergency departments, urgent care, and we see it even with those high-risk groups. There's some larger DSO group practices that are starting to identify their patients that are diagnosed as diabetic and linking them to a dentist, because we know the correlation between diabetes and oral health. In schools too. IDEA, which is the standard for American Dental Education Association, they oversee all the dental and dental hygiene and dental assisting schools. They have made the formal recommendation now that teledentistry is taught in schools, that they are teaching this to their students. Because now we're also seeing it as part of presentations. We're seeing it as outreach. They're utilizing it in a variety of ways, including skills checkoff list. We had one school who said, you know what, we identified our students don't know how to make a referral. So they're using it as part of teaching the referral process. So in a variety of ways, I have hygiene programs that are using it for oral health consult, nutritional training, in a variety of ways on those skills. When we talk billing and coding, now that we understand some of the uses, there's different codes that we use. So one common way we see teledentistry is in that periodic exam, that D0120. So the hygienist captures all the data, all the images, and then the dentist is going to provide that evaluation at a convenient time and communicate the findings with the patient. I have many patients that'll come in and they won't necessarily have a lot of issues, but we're waiting 20 minutes for a hygiene check because the doctor can't get up. They're interrupted by that time. Or we're doing it and we're increasing the efficiency so the doctor can be more efficient and stay seated where they're at. Again, this is very much a case-by-case basis, but it's commonly used. Another thing to consider for practices is how much do you save by shifting those post-op visits to virtual? I don't have barriers. I don't have staff time. I don't have room set up and breakdown. Most post-ops are usually scheduled on a 30-minute increment. That being said, most teledentistry visits are on average 15 to 20 minutes at the most. And we're seeing it outside the traditional setting. We're seeing the physical co-location. We're seeing the virtual co-location, where hygienists are connected to medical settings. Those medical providers sometimes will capture the data. Say if they come into an urgent care or an FQHC, and they're collecting that data and sharing it and connecting for that various expertise. One very, very common way, which is acceptable in Texas as well, is we're sending a hygienist into school-based programs now, because we know many of these children don't have access to dental care. So now either the school nurse is capturing the data and sharing it, or the hygienist is going in and they have remote supervision by the dentist. And we're connecting with the parent and we're connecting with care after that too. One big challenge we see with pediatricians and early childhood caries, and I know I've talked to my child's pediatrician many times in this aspect. They're seeing children that show up with dental caries, and they say you need to take them to a dentist, and that's where it ends. So we're seeing it now in many different states where a hygienist is spending a day or a couple days or a day a week in that pediatrician's office, providing preventative care, providing that screening, and then having the dentist making that referral back to the dental home. Or again, we're putting a camera, intraoral camera in the hands of a pediatrician office. They're capturing a couple images, areas of concern, connecting that family to a local dentist, giving them that dental home, and the dentist is providing the evaluation and getting that child in for care sooner. So there's many, many opportunities that we can do it. If we look at the billing part of it, say for instance, a school nurse, or maybe the CNA at the school, or at a long-term care facility, identifies a patient that has a need, they're going to go in and capture images and documentation. and assign that information to the dentist for review. How would you bill for this? Because we know that there is an ROI on teledentistry. We know there's codes and billing and money associated with it. And in many, many states, there's also Medicaid reimbursement too. So what we would do is we would bill for a photographic image capture codes that we have. We would bill the D0140, which is our evaluation code, and our asynchronous teledentistry code. Additionally, that medical site is probably going to bill for their services. And it's important to know how we connect and who bills for what. We see connecting to portable clinics too, bringing preventative care to those at-risk populations. This is done through teledentistry. We provide the basic medical screenings and Head Starts, nursing facilities sometimes. It depends where we're at. And we also provide the vital signs and medical referrals. So in dentistry, we have all these additional touch points that can be utilized and can be connected via the teledentistry aspect. We also look at value-based care because we know the reimbursement for value-based care is on the patient success, the patient-based outcomes. And many of our organizations do it in this manner. We know under value-based care agreements, the providers are rewarded, if you will, for patients improving their health, their overall or their oral health. So there's an earlier emphasis on prevention. We look at things like oral health coaches or concierge in that manner to help coordinate that care. We also have capitation plans where a dentist is prepaid for each patient on the plan monthly. So we're utilizing that chair time and increasing efficiency that we see with them, but we also have to bill correctly. And then we utilize the teledentistry for referrals, medical to dental, dental to medical, specialists on both ways as well. So when we talk about the abilities in Texas, now with teledentistry brought forward, we're seeing dental professionals are connecting with long-term care facilities. We can see special needs homes, especially education, treatment referrals, endocrinology, those with diabetes or higher risk factors. Many times now we're seeing a hygienist that is connecting with an OBGYN. We know that healthier moms will have healthier babies. So we get them the care they needed while pregnant and postpartum as well. And then that medical consultation. Referrals with teledentistry too, we look at the outbound referrals or inbound referrals. Teledentistry is more than just a limited exam. It really is, if we have an area of concern, maybe we're looking at oral cancer concerns. We know the longer it goes, the higher risk factors. So now we're connecting and making those referrals sooner. And by teledentistry, we're sharing that data, or we even get those real-time access, especially for rural patients that maybe have a long drive to see that oral surgeon, to get that evaluation. We can do that preliminary part to determine, do we need to see them in person for a biopsy based upon that and changes. So on the billing part and the reimbursement part, it's really important to look at our CDT codes. And it's often a battle sometimes because we often hear from patients, I'm only going to do what insurance covers. If we allow the insurance to dictate how you're treating your patients based upon their needs, you are completely doing a disservice to them. The CDT codes you bill are procedure codes. They are not insurance codes, they're procedure codes. And with teledentistry, with COVID especially, we've seen carrier reimbursement and the state legislation change. I applaud Texas for moving forward, allowing this. There's such a need for many, many of the patients for increased access. Teledentistry makes it possible. But what we're seeing is third-party payers like Aetna, Liberty, MetLife, Principal, DentaQuest, Blue Cross Blue Shield, Deltas, Guardians, Emeritus, Sun Life, and many, many states Medicaid, again, they're seeing the need and the increased access and the cost savings, are reimbursing those two particular teledentistry codes, the D9995 and the D9996 codes. Now, another thing that you often find is there is a parity law in place. That parity law means that insurance companies cannot reduce the rate they pay you for telehealth services compared to the same code for in-person services. If you get paid $45 for one, you get paid $45 for the other, regardless of the way your expertise is delivered. We're also knowing that even if they don't reimburse for those teledentistry codes specific, many of them, or actually all of them, if you're providing a limited evaluation and it's within that plan that you're reimbursed for it, you will get reimbursed for that limited evaluation regardless of how that was delivered, unless there's specific language or stipulations otherwise. But we're seeing more and more adoption of it. It is also important to know which provider bills for the teledentistry service. Because when there's more than one provider involved, say the hygiene or the dentist and the specialist, who bills for the code? It's the dentist that performs the oral evaluation and makes the diagnosis and would create the treatment plan is the one that reports the CDT code for teledentistry. So it's not the one that's making the referral, it's the one that provides the diagnosis. But how would we bill for it? We know that the D0140, our limited oral evaluation, is probably one of the most common codes we can use with it. Again, it is always in conjunction with the procedure you perform. If you bill the teledentistry code as a standalone code, more than likely it's going to get kicked out and denied. Always used in conjunction. We also have the D0170, which is a reevaluation of a problem-focused area. The D0171 is our reevaluation post-op visit. Periodic, again, D0120. And then we also have dental case management or care coordination. If we're coordinating care between multiple providers or medical and dental, we have a code we can use for that to submit. We also are going to build that teledentistry code if we're coordinating care between our patient and another provider and making that happen. We have our substance use codes. So we have our D1320, which is tobacco counseling for the control and prevention. And then we have our D1321. And this is counseling for the control and prevention of adverse oral, behavioral, and systemic health effects that are associated with high-risk substance use. This can be our alcohol, our vaping, cannabis, illegal street drugs, pharmaceuticals, chemicals, basically almost everything that does not fit underneath tobacco specific. Even if you were doing these two things in person as part of your procedures in office, you should be documenting this with the correct CDT code, regardless, because you want to provide that proof that you've done it and it's a quick reference back as well. We also have image capture codes. So we have some codes we can utilize that's captured by a practitioner not associated with the interpretation and report. So it means if I am capturing intraoral images and I'm sending those as a referral, I can utilize these codes for those image capture codes because I'm not providing the diagnosis or the interpretation from this. Somebody else is. There's also new codes in 2021 that are image capture codes. Again, these probably won't apply as much to teledentistry, but to be out there, the D0701 to D0709 radiographic codes too. So let's look at the reimbursement for teledentistry, and it says and PPE, but ignore the PPE part. Typically, we'll see a patient for a limited evaluation, post-op case management, Again, we're going to build that in conjunction with our teledentistry codes. One of the two. You're never going to use both. It's one or the other. Additional possibilities that we do have. We may be doing assessment of a patient via teledentistry. So we can't make the diagnosis, but we're determining the need if they do need to be seen in person. We also have the image capture codes. Now, if I'm capturing images remotely through my patient's device as part of my teledentistry encounter to make my diagnosis, I may do the D0350 code. So I may incorporate those together. So what if a patient calls you on the phone and, doctor, I have a problem. This is not teledentistry. If you're going to bill with this, and this is audio only, you may only be able to do the screening. We determine we need to see you in person. If we are seeing patients, a dentist who receives that with audio and visual means, they may be a limited exam, they may be a post-op, they may be a reevaluation, and it's a teledentistry code. So now we're billing for two codes. If we're looking at other examples of it, the patient contacts a triage center, call center, for the dentist to provide that code, or for the dentist to provide the evaluation using audio and visual means. That call center is going to bill the screening code because they're determining the need to be seen by a dentist. The dentist then would be doing either the limited evaluation, the post-op reevaluation, and the teledentistry code. And just as we talked about before, if a dentist is going to refer to a specialist with audio and visual via teledentistry, our general dentist is going to use that screening code because they've determined that that diagnosis needs to happen by a specialist. So I'm going to bill the screening code. My specialist is going to bill the evaluation or exam codes and the teledentistry code because they are providing the diagnosis. I, as a general dentist, would not be providing that diagnosis. Again, let's look at it again. So if a hygienist sees residents in a long-term care facility utilizing an intraoral camera and a laptop, I'm capturing the images, I'm capturing the data, and synchronous meeting, so real time, with teledentistry for the dentist for the evaluation, how would you bill this? What codes would you use? The hygienist is probably going to bill the assessment because they are making the determination to be seen by a dentist. Now, in the case in Texas, where you have to have supervision and the dentist has to see it anyway, we probably would not have billed that assessment code. This is more of an independent practice type of situation. But I could bill the image capture codes. So one or the other. Is it 2D imaging? Am I doing it as interpretation by another? And then I'm going to bill my evaluation code as a dentist and the synchronous teledentistry code as a dentist. So now we have a suite of codes available for teledentistry. We also look at the aspect of what documentation is required. So when we look at CDT codes and we have our standardized form that we have to fill out, most of the time this is electronic. We have our standardized form. What you must change in there is the place of service code on line 38. It needs to read 02 for telehealth. That point has to be changed because it identifies where service was provided. This can be in a variety of different ways. It can be in a hospital setting. It can be in an office setting, which is standard. Through telehealth, it needs to be changed to an 02. We're also going to bill, again, our teledentistry is never a standalone code. It's always in conjunction with our procedure codes that we do have. The 02 telehealth place of service code is right there on line 38, as I said. It must correctly reflect the location we're at. So I know I've thrown a lot at you and want to be aware of everyone's time as well. I think we're doing well on time and allow time for questions. My email is there. As you move forward with teledentistry and really look at implementing this, if you have any questions, please do not hesitate to reach out. And we'll address some of the questions we have here. If a patient sends you a diagnostic image, you follow up with a phone call to do a remote limited exam, can you bill this? If it is a phone call, you cannot bill teledentistry or a limited. The most you could do would be a screening. Can I have a telehealth encounter with emergency room staff, a nurse or physician, if the patient is not patient of record? In most states, I will say you can, especially if you are, the dentist would be able to do that as well. Again, look at the Texas regulations and how that falls about. That may be the referral part. I think, Beth, you were going to hop in on one too. Is that correct?
Well, yeah, I did get some feedback from the state board about that. And so I've got some a little bit of updated information about it. And the question you were on, which question were you on? I'm sorry.
It's disappeared off here.
Oh, it's already answered. So sorry.
Okay.
If a patient sends you a diagnostic image, that one? Or
Correct.
No? Patient of record.
Yeah,
patient of record. What I learned from the state board attorneys was that new patients can be synchronous or asynchronous. So you can sign them up via teledentistry, your new patients, either synchronously or asynchronously, which was a surprise to me. But that of course is at the front end of any of the appointments. And that'll be in the guide that we're publishing.
Wonderful. That's a wonderful option to have there too.
Yeah.
My only concern with that question is you're not joining audio and visual means. With that question, it said via phone call. If it is a phone call, that's not considered teledentistry.
Right. So what if, just another question, what if someone was out there collecting, say a hygienist was out in a remote area or at an alternate facility and collecting the data, doing the x-rays and collecting all of that data, sending it asynchronously to the dentist to diagnose and develop the treatment plan and all that. And then the dentist gets on the phone with the patient to discuss whatever the x-rays show or any of that, because they're looking at the electronic communications that they gathered asynchronously, but yet they're having a synchronous call with them on the phone. Is that
well, if they're looking at the data that's collected, and from my understanding, if they're looking at the data that's collected, they're able to have that in front of them. They're able to make that preliminary diagnosis. That part of it is teledentistry. They're able to do that.
So it would be
as far as I understand.
Right? Okay, synchronous code.
The asynchronous.
If they're talking to them live on the phone while they're looking at the screen, that's still asynchronous?
They're doing it when the patient is not in the chair with the hygienist. So that would be asynchronous because they're reviewing the data, not live. And the part they're going to bill is for that part of it in the professional diagnosis, not the phone call, because that phone call, just over the phone call, is not teledentistry.
Okay.
My recommendation would be to join much like we are now, because then that dentist would be able to share the screen, share the images, and really help the patient understand what they're interpreting from the data, or to have live be able to answer those questions that way.
Okay.
What are some recommendations of how, as we providers, can confirm that the patient is in your state and they are receiving the evaluation via teledentistry? Is there a way to identify their location via secure teledentistry software? I don't think you're able to location. That's a simple question when you ask them and just document. We can't control if a person tells you they're in Oklahoma or if they're in California. We have to kind of go with it. So.
And I believe that has to be on the informed consent that they sign of where those services were done, teledentistry. So that is filled in somewhere. It's on the informed consent where they want to know that part.
Yep. Let's see. Do we know where Texas Medicaid stands on reimbursement? We know this question was coming, Beth.
Right. And I've checked with Dr. Lacabou even yesterday to find out she's having to rewrite or write the teledentistry TAC policy rules. She's having to write something with that, but she said it's a lot of work. So she's been working on it for several months. I don't know if Medicaid is reimbursing or not. I don't think they are yet. Perhaps one of the Medicaid dental providers could tell us if they've tried.
On the telehealth claim form, what do you put in the location field? That is a 02 again. And that is line 38.
And I have a question for you, Jamie. Do all dentists use that form, or is that form different with each insurance carrier? So,
no, that is a standard form put forth by the ADA.
great.
So that is a standardized form that's supposed to be utilized with all insurance claim forms.
Okay, fantastic. Thank you.
It's just with the beauty of having it now being electronic, it's still the same form. Sometimes it'll look, you just have to extra click to open up the whole form versus just hit go, essentially. Some great questions that people had. So if the patient sends me pictures, I review the data. Would it be asynchronous telehealth? Yes. Again, I would highly recommend that you do that through a secure platform where you have record of them. Having them on your personal, like through via text message, does leave you open to, HIPAA compliance issues as well. Any other questions?
Well, there was one other question up at the top. Would you please direct us to a template for informed consent? I will love to let everyone know that we have a fillable PDF template for the informed consent that's going to be in our teledentistry guide, so that anyone can use it. They can put their logo, their practice information at the top of that form, and then everything is fillable, so they could put it on their website where people could you could get it there, or send it electronically. So that should be pretty handy for everyone. But I feel sure, Jamie, that there's some others out there. It was just hard to find them, so we kind of made one for Texas.
It is. And if it's based on Texas, I think that's a wonderful thing. And any idea when that'll be released, Beth?
I'm thinking it's going to be, we just met with 3 of the attorneys from the state board yesterday, and so they kind of signed off on what we have. We need to do some final edits, but it should be published before our next webinar in October. And our next webinar in October is October 14th, and then the third webinar will be November 11th. So that's where we are on that, but it should be coming out pretty soon. Now we've got to pretty it all up, make it nice. So that's where we are with the guide so far.
Wonderful.
Let me look.
Well, again, thank you to everybody. It's been a pleasure to be able to present to your group, and I look forward to those in Texas being able to extend this possibility of care to all your residents.
And thank you, Jamie. We appreciate you presenting today for us so much. It was very informative, and it gave a great overview of everything. I'm reading from Elizabeth Stanford. Elizabeth, can we unmute her? Texas Health Steps is our children's Medicaid, so she may have some new information. Elizabeth, are you on?
I am. Can you hear me?
Yes.
Okay, good. I did put in the comments section the latest that we received at our last meeting with HHSC. Like I said, Dr. Lackaboo is still doing her part, but they have been working on this for quite a while. Went through the process of having comments, the public review and everything. So that's closed up. And so we're hoping, soon. And it gets so confusing. So no more, they got to be 3 years age and older to be able to do the teledentistry. And there's been talk that it might just be when there's a, the emergency health declaration like we're in now. So just not, kind of waiting to see what they decide about that. But like I said, that was just the latest that we had received about House Bill 4.
Okay, well, I hadn't heard that part about the children, so thank you, Elizabeth, for
Sure.
that update. I really appreciate it. Jamie, again, thank you so much for your time today and your presentation. If anyone has any questions, please reach out to us for more information at info@texsoc.org. We're happy to respond and find out whatever we need to help you. So with that, I will say goodbye and thank you again for your time and have a good afternoon, everyone. Thank you so much.
Thank
Bye-bye.
you.